I'm Scott Carson, Director of the Monieson Center for Business Research in Healthcare. We were delighted to bring Dr. Jonathan Kolstad to Queen's School of Business as a part of the Monieson Center's Economics and Healthcare Speaker Series. Dr. Kolstad is an assistant professor of health economics at the Wharton School. In his paper, he drew upon the Massachusetts healthcare reform of 2006 and the more recent Affordable Care Act to examine a focal policy element of these reforms, mandating individuals to obtain health insurance. He also talked about a model to determine the welfare impact of the actual policy, as well as to estimate the socially optimal penalty level. Here is a portion of my interview with Professor Kolstad. So you gave us a terrific paper today, so just set it up a little bit. Tell us a little bit about the research and explain a bit about adverse selection and why that's so key to what you're doing.
Absolutely. So I think this paper is, as I mentioned, part of a broader stream of research using the Massachusetts reform to evaluate these big policy questions that come up under the Affordable Care Act. And frankly, we care even intrinsically about Massachusetts. It's only one of 50 states, but it's still a fairly reasonable number of people. Mm-hmm. But the goal of this paper is to understand how implementing an individual mandate to have health insurance impacted adverse selection. And so, to be clear...
So an individual mandate is the requirement of people to purchase insurance.
Exactly. And specifically, in this case, it's the requirement that people purchase insurance or pay a penalty for not having that insurance. Right. So that's how it's enforced. And the question here is whether or not that affected adverse selection. And adverse selection is the notion that people have private information about, in this case, their cost of insurance, and that they're going to be more willing to buy insurance the more sickly or more costly they are. And there's canonical economic theory basically showing that can lead to either markets not existing. So because only the sickest people are willing to buy, so for example, if I offer a premium for an insurance plan, if only people whose cost is higher than that premium are willing to buy it, then I'm not going to offer that insurance plan at all. Or another canonical theory result from Rothschild and Stiglitz basically is that you might have distortions in the contracts offered. So you may get markets, but I'm going to offer a less generous plan to some populations. So that's been a long theoretical result, and there's a growing literature testing this empirically, but most of that was done in other contexts, like an employer context. So do you get adverse selection? Do sicker people buy the more generous plan offered by their employer? Very interesting, very, very important work. Within the economics profession and from a policy perspective. But that may say less about what we expect to be going on in Massachusetts and nationally, which is getting people who don't have any insurance at all into the health insurance market. And so what we're doing in this paper is basically asking the question, A, were the people who we see newly insured as a result of the reform more or less healthy than the people who were insured beforehand? That's just a test for adverse versus advantageous selection, which is what we call it when the relatively healthy signed up first. And then the second one is to actually say something about, was this a big problem? Was this a small problem that we've overcome? And how much better off was society as a result of this change? And the way to do that, we need not only the underlying cost of the people who were newly insured, but also how much they were willing to pay for insurance, right? And it's a very simple welfare criterion that we use as economists, which is to say, if there are people for whom they're willing to pay for insurance more than it costs to give them insurance, that's the welfare loss, that those transactions should occur. And if they haven't occurred due to adverse selection, the degree to which an individual mandate reduces that, meaning makes people who are willing to pay more for their insurance than it costs to insure them take up that insurance, then we think that we want to measure that welfare gain.
So what did you find?
So we find, in fact, that that the market there was adversely selected beforehand. I think there's an important caveat there that Massachusetts beforehand had what we call community issue and guaranteed issue and community rating regulations, which basically restrict the premiums to be, you have to offer at a very simple level the same premium to all individuals, and you have to offer them the insurance if you want it. There's certainly reason to think that might exacerbate adverse selection in the first place. So just to put the caveat that we're looking for our keys under the streetlight where we think there might be some adverse selection. On the other hand, or what we do find is in fact that was the case. Now, interestingly, when we measure how much those people are willing to pay for insurance, it turns out that they are much of the individual market population in Massachusetts, that is people that did not have insurance through their employer, they had a very high willingness to pay relative to the cost of insuring those individuals. So we find that basically the welfare gain due to the increase in adverse selection was substantial. The decrease in adverse selection was substantial. That you move to near universal coverage. So
more people are coming into the market who are...
Exactly. So we find, roughly speaking, about 70% of people in the individual market had insurance beforehand. By the end, that increased to 97%. So close to near universal coverage in the individual market. And that population had a higher willingness to pay than the cost of their insurance. So the total value of that in dollarizing the welfare was about $93 million a year, or 8.5% of the total cost of the medical care received by that population. So that's a substantial impact on people's welfare as a result of the...
and that would bode well, of course, for Obamacare as well in terms of accessibility.
Yeah, I mean, I think it points to a couple features. I want to give a couple parallels, but there's also some important caveats. It does suggest that this individual mandate can be an effective way to actually get people into the market. So it does seem to be shifting people into insurance. And it also suggests, and one thing I didn't mention as much, is we differentiate two effects. One is that the individual mandate can just induce people to buy insurance because it effectively lowers the price of insurance. Mm-hmm. If I charge you a penalty if you don't buy a good, well, basically that good is cheaper because if you don't buy it, you're going to
pay it anyway.
Burn your money, right? Exactly. The other effect we allow for is that competition could have changed in the insurance market. And we think that might happen both in Massachusetts and in national reform for a number of reasons. One is it's an opportunity to introduce new insurers into the market. Two is health insurance exchanges are these marketplaces that are set up either on a state-by-state basis or in some cases under the ACA. The national exchange is available in particular states. But that can basically make more transparent pricing, more transparent attributes of plans, and we think it might make a more competitive insurance market. In both of those cases, you're going to basically lower that premium and lead to a reduction in adverse selection because more people are going to move into the market. As long as their willingness to pay for that insurance is higher than the cost, that's going to make people better off. So we do find pretty substantial welfare gains. Now, does that portend very well for the ACA? I think there is a reason to believe in states where there's adverse selection in the first place that the ACA could be very effective, and we could see similar results. And you've seen in some states, particularly those states with these guaranteed issue and community rating regulations in place. So, for example, New York, on their individual exchange, or their health insurance exchange, you saw large reductions in the premiums being asked on that exchange, consistent with a number of different features, but certainly plausibly a response to the adverse selection that might have existed beforehand. Now, where it might not be as good a parallel are there's other states where you don't have this community rating regulation. So if you don't have to ask for one premium from everyone, you may not have had as much adverse selection beforehand. Mm-hmm. Now, there's a lot more policy, broader policy questions around whether or not it's good to induce pooling and get everyone into the market. But certainly the welfare implications we find where it's an adversely selected market and we're mitigating that may not hold in those states. Though I think there's evidence for other reasons that it might be a productive policy in those states. But I want to give the caveat that in some states this is really a good parallel. In other states, maybe less so.
You really stimulated my interest on the adverse selection because I hadn't really thought prior to reading your paper as much about the rational decision-making processes of consumers when they purchase insurance. Now, your paper doesn't specifically deal with this, but I thought I'd ask you about it anyway. I can see that a person with a pre-existing medical condition that's quite serious would want to insure against that. But I'm wondering about people such as those who have risk in their lifestyle, smokers, for instance, or those who engage in risky, say, recreational activities. Do you think that they too select insurance and make decisions about insurance because of those aspects of their lifestyle? Because isn't it the same kind of risk or disposition to take risks that causes people to go off and do, extreme skiing that would play a role in them not being as inclined to buy insurance?
Yeah, no, I think there's a couple of excellent points there, and most of this boils down to, what's going into that demand for insurance, and to what degree do we think that's going to be correlated with the underlying cost. And so, it's interesting you bring it up, not in this paper, but actually in another line of work. I really have studied basically the consumer decision-making in insurance markets and whether or not informed consumers are or are not informed, and can we account for those features? And if so, kind of how does that impact policy questions like adverse selection, in fact. And what we do find there is that there's a large share of the population who don't have the sort of rational or the degree of information we think is implied by kind of a rational decision maker, which is going to, weigh what's the probability of my becoming sick and how risk averse am I, over the next year when they make that decision. And there's certainly reason, both from that research where we link individual survey data to the actual costs and insurance decisions of a large group of individuals. And we find there that accounting for those information frictions, that is, I don't really know, A, the terms of the plan directly, or B, my underlying risk very well, that can have very large implications for which plans people select, and also, as a result, how much adverse selection you do or don't get. So that's I think an important piece to this, and an area for ongoing research, which is how do you take these models? Again, here we just assume, look, there's demand for insurance, and we assume implicitly that it's rational, right? That my willingness to pay reflects my underlying preferences for insurance. But if that's not the case, we're going to get different public policy implications, and I think there's a lot of reason to believe that that's important from a research perspective. It's also an opportunity from the perspective of an exchange, a health insurance exchange, be it public or private, or an employer, or whoever's offering insurance, to provide these tools to basically facilitate consumer decision making. And there's questions around how that's going to actually impact both adverse selection, matching of consumers to the plans that they prefer. Those kinds of questions are going to be really important going forward.
So I can see you're going to have to make many visits back and have more discussions. So I want to just, I couldn't let an American economist go without asking for the crystal ball. So looking forward at insurance and insurance policy in the U.S., knowing what you know from the research and seeing where we are with Massachusetts and the beginnings of the Affordable Care Act, where do you see things heading over the next 5 and 10 years?
Yeah, I mean, I think it's one is a little bit reticent to do too much prognosticating.
Oh,
but
come on, typical economist.
Exactly. I mean, I think there's some good evidence that's suggestive of a couple important trends. So, and I'm going to rely a little heavily on Massachusetts here, but we have had at this point, 7 years of Massachusetts reform, effectively, to give some evidence. So, the first off is, I think that, as I mentioned earlier, that these hiccups around the exchanges in the U.S. are not going to be detrimental over the long run specifically. What I do see is that there's going to be an evolution and a lot of learning in these exchanges, and there's going to be some big winners and some big losers. And I say that both with respect to the public exchanges, but I also see a lot of private exchanges coming into play. And you hear this a little bit, particularly after kind of healthcare.gov. Well, there are private players out there that are also offering standardized products. And so it'll be interesting to see how that plays out, particularly given that in different states you have different exchanges and different designs across those states. Two is the implications for the labor market. And so in some other work that I've done, again, with Amanda Kowalski, my co-author on this paper, we looked at the labor market impact of health reform. And what you saw in Massachusetts is, in fact, that the newly insured, those people that were moved into coverage, seemed willing to pay for their insurance insofar as they were willing to take basically wage cuts almost exactly equal to the cost of that new insurance. And what that's suggestive of is that you won't see large reductions in employment. And rather, what you've done with an individual mandate is you basically induce a valuation for insurance. And so for those people, what you might see as a transfer from wage income to insurance coverage. But I don't think, and to some degree, the Congressional Budget Office is consistent with this overall, that you don't see amongst the prime working age population large reductions in employment associated with it. So I don't see that. But frankly, broader prognostication about health reform. I mean, I think it's now moved to a point where 6 million new people have insurance. Everyone has the expectation of having insurance. I certainly don't see any kind of repeal being politically feasible. And in fact, I see over the longer run potentially even more shifts away from employer-based coverage and towards more of these exchanges, even more broadly. I don't forecast that immediately. Again, in Massachusetts, what you saw is quite the opposite. More employers offering insurance, because that's a way to differentiate yourself in the labor market. If everyone demands insurance and you can efficiently offer them insurance, you do want to offer it to them. But over the longer run, so say the next 10 years, I think there will be opportunities in which individuals, employers say, look, I can offer a broader suite of products less expensively to my employees through an exchange, and you may see that shift going in that direction. And I think there's good things and bad things about that with respect to both the function of the labor market, the quality of insurance people get, and ultimately what we really care about is their access to health care and their health. And so that'll be, I am optimistic that will be productive, but there's certainly going to be bumps along the road. And one nice thing about the approach that's been taken, it really is this federalist approach, which is different states are doing different things. And so one thing I hope, but you never know with politics anywhere, particularly in the states right now, is that there's the ability to learn from successes in places that there are failures, because some states are going to be very successful and some states aren't. And the ability to take that information and translate it into policy and translate it into action is a great opportunity, but it takes both policy understanding as well as political will. And so I think that the latter is more of an unknown at the state or federal level going forward.
Well, John, that's terrific. Thank you very much.
Thank you very much.
Thoroughly enjoyed it.
Absolutely.
I've been speaking with John Kolstad from the Wharton School in the Monieson Center for Business Research and Healthcare Economics Speaker Series.